Hello, this is David Quaig, Vice President of Scientific Support for Doctors Data Laboratory. What I want to talk about today is testing beyond the standard of care for cardiometabolic syndrome. Now, the reason this is such an important topic for your patients and in your practice is that the CDC has released really depressing data. Let's start with the fact that in the US, heart disease remains the #1 cause of death, affecting about 25% of both males and females. To add to that, greater than 60% of both males and females are over fat or overweight, and not surprisingly, the same holds for our children at an estimated greater than 30%. Now, when it comes to metabolic syndrome, there's no question that that's highly underdiagnosed, but estimated to occur in about 25% of adults and an alarming percentage of children. Now, clearly, these conditions are in large part lifestyle choices, and prevention and early detection of the silent risk factors for heart disease, metabolic syndrome, type 2 diabetes are paramount to prevention. And highly sensitive and specific laboratory testing can facilitate early intervention. So what I want to talk about today is a very depressing topic, so I want to try to lighten the subject a little bit. We have this big fellow on the scale here, and he thinks he's retaining water, but his doc tells him, no, bud, you're retaining food. And the problem is this central or visceral adiposity, and we're all familiar with the problems associated with the abdominal fat and the apple shape. So with 2 mils, from just 2 mils of serum, we look at lipids, lipoproteins, apolipoproteins, arterial inflammation, markers of dysglycemia, the adipocytokines, and renal damage. Now that's a whole lot of stuff to cover in about 15 minutes, so I'm going to really focus on oxidized LDL, small dense LDL, the lipoprotein-associated phospholipase A2 activity, and the primary adipose cytokines. Now, simply measuring LDL cholesterol is useful for justifying prescribing a statin. However, if we look at the percentage of coronary artery disease patients in risk quintiles across LDL levels, we can see that when we go from very low LDL to very high LDL, there's not much change in risk. But that's not the case when we plot the same thing with oxidized LDL. You see a beautiful linear relationship. The higher the oxidized LDL, the higher the risk for coronary artery disease. So let's talk about oxidized LDL. It is one of the real LDL culprits. And oxidized LDL really refers to the oxidation of the ApoB moiety that covers 2/3 of the surface of a normal LDL particle. That happens when the LDL enters the arterial wall. That oxidized ApoB is no longer recognized by the normal ApoB receptor, but rather is recognized by the scavenger receptor on the monocyte-derived macrophages. As the macrophages just take on and engulf this oxidized LDL, they become very large and they call for help. They release chemokines to pull in more monocytes, and they also release pro-inflammatory cytokines. Now, increased levels of oxidized LDL are independently and linearly associated with coronary artery disease. And middle-aged men with high oxidized LDL have 4 times greater risk for developing coronary heart disease. Further, individuals with high levels of oxidized LDL are 3.5 times more likely to develop metabolic syndrome within 5 years, a very impressive study. Oxidized LDL induces adipocyte inflammation, proliferation, and insulin resistance. All that is associated with lower adiponectin, which we'll talk about in a minute. The second main LDL real culprit subspecies is small dense LDL. It's a very strong independent risk factor for coronary artery disease. It's associated with elevated triglyceride levels and low HDL, that is low HDL2, the larger, more buoyant anti-atherogenic HDL species. So what happens is when we have an expanded VLDL triglyceride pool, there is a net transfer of triglycerides into what is normally just a cholesterol ester-rich particle, the LDL, such that the LDL now becomes loaded with triglycerides. Then those triglycerides are cleared by lipoprotein lipase and hepatic lipase. We get rid of the triglycerides and end up with a very small, dense cholesterol ester-rich LDL particle. So these cholesterol ester depleted readily, small dense LDL readily penetrate the endothelium. They carry less antioxidants, and yes, LDL carry not only glutathione peroxidase, and tocopherols. So they're readily oxidized and taken up by those macrophage scavenger receptors in the arterial wall. Intervention: reduce the simple carbs in the diet, lower the triglycerides with niacin, fish oils, fibrates. Now, the lipoprotein-associated phospholipase A2 activity is an extremely good indicator of the disease process. So when we see elevated LP phospholipase A2, we think of a macrophage activation and disease progression in the arterial wall. We're measuring this in serum, but it's telling us what's going on in the arterial wall. So when the plaque interacts with oxidized LDL, it causes greater inflammation and invokes plaque instability. That's associated with a doubling of risk for coronary artery disease, acute myocardial infarction, and coronary heart disease related death within 7 years. And it has especially high prognostic value or information when associated with metabolic syndrome or type 2 diabetes. Now, metabolic syndrome comprises a cluster of cardiometabolic risk factors with insulin resistance and adiposity as its central features. So identifying individuals with metabolic syndrome is important due to its association with silent increased risk of cardiovascular disease, type 2 diabetes, hypertension, and even kidney disease. Now, research attention has focused on the visceral adipose tissue production of these adipocytokines in metabolic syndrome type 2 diabetes, because the levels of anti-inflammatory adiponectin are lowered while the pro-inflammatory adipocytokines such as leptin are elevated. And that creates a pro-inflammatory state associated with insulin resistance as well as endothelial dysfunction. So let's talk about this one marker. Of course, you measure glucose, fasting glucose, but Glycomark, the 1,5-anhydroglucatol. Now, typically one would try to monitor blood glucose levels using hemoglobin A1C, which shows you just a time average over the past 3 months in the plasma glucose. But the 1,5-anhydroglucatol, the 1,5-AG, indicates more frequent episodes of extreme hyperglycemia. And the way that works is that the 1,5-AG is a naturally occurring dietary sugar-like molecule, the serum levels of which are very steady. However, when significant hyperglycemia occurs, like postprandially, when we get up to greater than 180 milligram per deciliter, the resorption of the 1,5-AG is disrupted, and it spills into the urine. That results in a lower level of serum 1,5-AG, so an indicator of frequent episodes. So low serum 1,5-AG indicates frequent and high hyperglycemic episodes over the last 1 or 2 weeks, and detects significant swings in glucose, even if hemoglobin A1C looks acceptable. Postprandial hyperglycemia is associated with cardiovascular disease, so a reduction of hyperglycemic episodes appears to decrease macro and microvascular complications in diabetics. And low 1,5-AG may also be associated with renal disease, another risk factor for cardiovascular disease. Now, these adipocytokines are fascinating. We used to think about adipose tissue as a baggie full of lard or a sack of fat. But in fact, adipose tissue is a very, very active endocrine organ in and of itself. It secretes these peptide hormones or cytokines, particularly from the white fat, not the brown fat. And these adipocytokines modulate inflammation, insulin release and sensitivity, hepatic fatty acid and triglyceride metabolism, oxidative stress, arterial integrity, and satiety. Now, leptin was the first adipocytokine that was discovered, and it's known as the satiety hormone because it inhibits appetite by signaling at the hypothalamus. But it also stimulates fatty acid oxidation and glucose homeostasis, and modulates body fat. Now, the problem is that increased abdominal obesity is associated with increased serum leptin. Leptin, that sounds great, okay? Leptin. But that's associated with leptin resistance, which is rather selective with respect to different tissues. For example, elevated serum leptin is associated with a loss of that satiety signaling in the face of plenty of food, but it stimulates sympathetic nerve activity in the central nervous system, the adrenals, the catecholamines, the kidneys, and heart, and increases vascular inflammation, oxidative stress, insulin resistance, hypertension, and an atherogenic lipid and lipoprotein profile. It's associated with metabolic syndrome, type 2 diabetes, cardiovascular disease, and hypertension, acute myocardial infarction, as well as stroke. So we don't want to see high serum leptin. Now, adiponectin is known as the anti-inflammatory adipocytokine. It is the most abundant adipocytokine in blood, and it modulates insulin sensitivity, energy balance, hepatic and muscle fatty acid oxidation, hepatic triglyceride secretion, and supports proper endothelial cell function. For example, normalizes or increases the activity of endothelial nitric oxide synthase. But when serum adiponectin levels fall, they plummet, they decrease with increasing abdominal obesity or visceral fat. And that creates a pro-inflammatory cytokine state and a highly oxidative stressful state that's not only the reactive oxygen species, but the nitrosidative stress associated with the reactive nitrogen species as well. So low serum adiponectin is associated with obesity, type 2 diabetes, hypertension, coronary artery disease, and even left ventricular hypertrophy. Now, even more sensitive than measuring adiponectin and leptin alone is looking at the ratio of leptin to adiponectin in the serum. They have opposing effects on the chronic inflammation. An increased ratio of leptin to adiponectin has been associated with increased incidence of cardiovascular disease in men and has been shown to be an independent predictor of arterial intimal medial thickness. Recent evidence indicates that the ratio of leptin to adiponectin is more clinically sensitive than either adipocytokine alone with respect to metabolic syndrome, type 2 diabetes, and cardiovascular disease. So my take-home messages are really quite simple. Risk assessment is not necessarily diagnostic. It very well may be for metabolic syndrome, but in any case, it can guide preventive intervention, both on your part and the patient's part, primarily lifestyle changes for the patient. The serum levels of the real LDL culprits provide much greater clinical sensitivity and specificity. A large VLDL triglyceride donor pool, if you will, has adverse effects on both LDL and HDL size, and most importantly, the metabolism of those particles, and thereby risk for cardiovascular disease, and that's mediated by the lipid transfer protein. High oxidized LDL, bad. High phospholipase A2 activity in serum, bad. Low serum 1,5-anhydroglucatol, bad. A high ratio of leptin to adiponectin, bad. All beyond the standard of care. So the bottom line is that advanced risk assessment can facilitate individualized clinical and lifestyle interventions. Good luck with lifestyle interventions and motivation. For example, patient does the test. You see these horrible results. You intervene. You start introducing your clinical therapy, and you try to motivate the patient to modify their lifestyle. Get up off your butt. Get away from the computer. Get away from the TV. Do those things. Lose weight. Drop down a couple sizes, maybe 1 or 2 in your jean size. Come back to the clinic, get retested, see a marked improvement in those risk factors for both cardiovascular disease and metabolic syndrome. And then that is very motivational to keep people on the changes that you have induced as well as what they have undertaken. That deserves a real big pat on the belly or pat on the back, any way you want to look at it. So I thank you kindly for your attention. And for further information, please contact us at our 800 number or at info@doctorsdata.com. Again, I thank you kindly for your attention.